So now it's time to give the word to Dr. Française VEYCKEMANS, who is coming from the north of the France, and who is going to do a presentation about quality in pediatric anesthesia, but other indicators than complications.
Thank you, Isabelle. In fact, the real topic of this short presentation is how to set up a quality control or quality improvement system in a small department. We have to start with first thing first. So we have to know our own data. We have to, before being able to compare, we have to measure what we do. And so we have first to decide which indicators are relevant to our own practice. It means complications, of course, such as those presented by Professor Haber, and other indicators. I will come back to that in a further slide. We have also to set up a reliable data recording system in which we can include epidemiologic data, the number of patients we anesthetize each year, the number of patients by each age categories, neonates, infants, older children, and also data which can describe accurately our hospital case mix, how much in and out patients are undergoing cardiac or neurosurgery or burns, etc. And last but not least, we are also to convince our colleagues to play the game. So we had to create a team spirit, because without enthusiasm, this doesn't work. Regarding complication, we can collect data on adverse respiratory events such as laryngospasm, bronchospasm, aspiration, or postoperative pneumonia, adverse hemodynamic events such as cardiac arrest, bradycardia requiring atropine, or hypotension requiring vasopressor, or others. For example, how much local anesthetic blocks fail, or how much drug errors are reported. Using those data, we can compare our performance and use it as a tool for benchmarking with large epidemiologic data, such as, for example, those from Apricot. But we should keep in mind that we have to define clearly each complication. We have to use the same definition in the team, because someone can define as laryngospasm an event that can be defined as something else by his colleagues. So everyone should agree upon the same definitions. Regarding non-complication data, we have to choose. And we can, for example, use the percentage of readmissions of outpatients and try to define whether the cause was surgical, anesthetic, or social. We can also look at the actual duration of preoperative fasting. When did the child actually eat or drink for the last time, and why were the preoperative instructions followed or not? We can also look at quality of post-operative analgesia. We can look at prescription, administration of what was prescribed, and evaluation of the analgesia. We can also look at post-operative nausea and vomiting, or, for example, at parental or child satisfaction with anesthetic services, with a questionnaire, telephone call, or regular audits. The second step, once you have the data, you have a numerator and a denominator for each complication you have chosen, you have to perform regularly statistics, either annually or 6 monthly. I would propose more 6 monthly, so you keep the enthusiasm of the team going on. So the statistics should be shown and discussed openly in a team meeting. And so you can compare your results with recent literature or with your previous results. So you can start this process only the second year of collecting data. And if the incidence is similar, you're probably okay. If the incidence is increasing, you're performing worse. So we have to try to identify the reasons and take action to correct that and reevaluate 6 months later. And so you have also to prioritize problems. You can't solve everything at the same time, so perhaps the more dangerous first. But there are problems. The first is getting started. As for any human project, you need a clear goal, a strategy to achieve that goal, and leadership to make it work. The second is funding, because all this data collecting system and analysis needs some time. So you need either staff or giving some out of clinics time to your staff to work on it. And we all know that poor quality produces increased health costs, but we have to convince our administrators that good quality is often financially not visible, but should be done. And the last point is persisting over time. We have to maintain the enthusiasm of the whole team. And it could look sometimes as the myth of Sisyphus. You know, the man was rolling a rock up the mountain, and then he had to get it back when it rolled downwards. Thank you.
So thank you, Francis, for this very clear presentation. So I have a question. You have listed a lot of criteria of quality, but which one is the most relevant? And which one can I choose? It's not easy.
I think we have first to look at safety. And I would go for, and because respiratory events are the most frequent, I would go first for the most frequent one. So look at the respiratory critical events. Mm-hmm. And to choose as an objective to improve quality. And then you can look at the same time, a less life-threatening events, such as post-operative nausea and vomiting. How many of us know their numbers? Many people do not know how much of their children actually vomit after anesthesia. We should know that.
Yes, of course. So what do you think about morbidity, mortality meetings? Are they still necessary for you?
In my mind, they are mandatory. And they should be frequent. They should include, of course, mortality cases, high morbidity cases, but also near misses. Sometimes we are lucky. Something went well without any harm to the patient, but we should look at the causes of the event and try to correct it, either in the system or in the people who are working.
Okay. So another question, which is the best way, according to you, to evaluate parents and child satisfaction with anesthesia quality or services?
It's a difficult issue because usually you give a letter when they leave the hospital, but their mind is occupied by other things. They have to go back home, try to find a pharmacy, anything. So it's not a good time, and it's only usually thrown in the away. So I would say either you can do it, give a letter, and they can with a pre-filled envelope, so you pre-stamped envelope, so they can send it back. But there also we could have a bias. Either people who are very happy or very unhappy will respond, but that doesn't matter. The other way, perhaps, but it's cost, is to ask a nurse, someone neutral, to give a phone call 1 week after going back home. So people have they can give you information about the in-hospital stay and the first day after leaving hospital.
Yes, of course. And regarding post-operative analgesia, which is a good target for us, how can we evaluate this post-operative analgesia? I mean, when it is the best moment?
It depends on the setting. If it's an outpatient, I think we should organize a system where a nurse calls the parents the day after surgery. So we have an idea on the quality of the first night, and we can evaluate whether the parents actually understood our instructions, and we can even give some small advice on some problems. If there are big problems, you can even recall 1 day later. For people who are in the hospital, we have to make a system with our nurse reference for pain to evaluate, to look whether pain was actually evaluated, how many times, and what were the results of the analgesic treatment.
Okay. And regarding the recording system of complications, of course, everybody would like to have such a system, but you know, it's very, very complex and time consuming. And so how do you imagine to plan this kind of system?
There are systems already on the market that are usually not that user-friendly. I would try to have something simple, very easy to fill in, quick to fill in, because we are all busy, but which would be mandatory. And perhaps the best way is that you are unable to close the patient's file as long as you didn't click on the button complications, yes or not, and if yes, you have to push on select which complications you encountered. But of course, you can always cheat the system. But at least if you have a good team spirit, it could work. Okay,
so for you, reporting of adverse events should be mandatory.
Yes, because voluntary report can work, but we are human beings, and we can also try to avoid reporting to others when we failed.
Okay, and for the morbidity mortality meeting, at which frequency do you plan this kind of meeting?
I would say once, if you have no big problems, once every 2 months.
We have another question from...
we know now that many patients are operated in outpatient mode. So do you think that new devices, electronic devices, can help us to access the quality of what we are doing during the intraoperative period? I mean, the patient has the electronic device that is connected, and he answered the question like, do you feel pain? Do you feel well, etc.?
Of course, but there are many. Not everyone has a app,
of course,
and not everyone is able to use it, and so we have. Probably in the near future it will be more universal and maybe
I think there's a limitation for this, is the confidentiality of the data and which server were you doing. And that's our problem in Europe. We are unable to promote such a thing because of this confidentiality and where to put the data and who is going to treat the data. And that's a really big problem.
Yes, but can we think that we overcome this problem of
hopefully.
So, it's a connected patient.
Yes.
Everybody is connected, but we have to stay secret
children.
for the patient.
To protect private life.
Absolutely.